All right, let's jump right into a truly fascinating biological narrative. We're looking at exactly what happens when the body's elite internal defense system loses its directory of safe targets and essentially goes rogue. Welcome to this explainer on autoimmune polyendocrine syndromes. Today, we're going to explore the genetic glitches and the real-world clinical consequences that pop up when our immune system mistakenly turns its crosshairs on our very own endocrine glands. Think of this agenda as our clinical rounding sheet for today. We'll quickly cover APS-1, the childhood triad, APS-2, Schmidt syndrome, immunotherapy delays and triggers, IPEX and thymic tumors, a few rare endocrine syndromes, and then we'll wrap the whole thing up with a master comparison of APS-1 versus APS-2.
Okay, Section 1, APS-1, the childhood triad.
To understand ASP1, you have to understand the AIR gene, because its loss dictates this entire disease process. Normally, this gene is expressed right in the thymic medullary epithelial cells. You can think of it as the ultimate training manual for the immune system. Its entire job is to present tissue-specific self-antigens, things like insulin, to developing T cells, basically teaching them what not to attack. But when that AIR gene suffers a mutation, usually an autosomal recessive one, those autoreactive T cells completely escape central deletion. They get released into the bloodstream, fully armed and ready to attack the body's own tissues.
And that breakdown in tolerance brilliantly illustrates the can-hypo-add mnemonic. This perfectly maps out the precise chronological order these symptoms appear in nearly all APS-1 patients. First up, mucocutaneous candidiasis emerges. This is almost always the initial manifestation, and it's driven by specific anti-interleukin antibodies that just cripple the body's fungal defenses. Second, hypoparathyroidism shows up, bringing along low calcium and tetany. And finally, Addison's disease, or primary adrenal insufficiency, develops. Keep in mind, if you see just two of these three major components, you've got yourself a confirmed diagnosis of APS-1. Now, listen up, because I need to emphasize this literally life-or-death clinical caveat directly from the source material. Primary hypothyroidism actually prolongs cortisol's half-life, which means it can effectively mask an underlying adrenal insufficiency. So, if you see a patient with these autoimmune clusters and you immediately give them thyroxine without checking their adrenals first, well, their metabolism speeds up, the remaining cortisol clears out, and you will trigger a lethal adrenal crisis. Always, always screen for Addison's first. No exceptions.
Moving right along to Section 2, APS-2, Schmidt syndrome unveiled.
So, unlike the childhood onset of APS-1, APS-2, which you'll often hear called Schmidt syndrome, peaks in adulthood. We're talking mostly between the ages of 20 and 60, and it affects women at least 3 times more often than men. Genetically, it's heavily linked to the HLA-DR3 and DR4 genes on chromosome 6. Here, Addison's disease acts as the major central component. In fact, if an adult patient develops Addison's disease in this context, they have about a 50% chance of developing another autoimmune disease during their lifetime, most commonly autoimmune thyroid disease or type 1 diabetes. Speaking of diabetes, the crucial point here is that in these autoimmune clusters, the appearance of 2 or more autoantibodies guarantees a near 100% lifetime risk of developing clinical type 1 diabetes. It happens in stages. Stage 1 is when those antibodies first appear, but hey, glucose is still normal. By stage 2, glucose tolerance starts getting impaired, but they aren't fully diabetic yet. And then, stage 3 hits. That's when clinical symptoms and overt hyperglycemia finally strike. Let's shift gears a bit. Section 3, Immunotherapy, looking at delays and triggers.
3 years, I really want that number to sink in. This represents the average number of years the anti-CD3 monoclonal antibody drug, teplizumab, delays the clinical onset of type 1 diabetes when it's given to a patient in stage 2. This is huge. It's an FDA-approved milestone, the very first disease-modifying therapy for type 1 diabetes. By modulating T-cell activation and basically forcing an exhausted T-cell phenotype, it buys the patient a significant, life-changing amount of time before stage 3 sets in.
But, of course, immunotherapy is a double-edged sword. When we use cancer immunotherapies like PD-1 or CTLA-4 inhibitors to intentionally rip the brakes off the immune system to fight tumors, we can accidentally trigger some incredibly severe immune-related adverse events. Think about classic type 1 diabetes. It's slow, it has that stage progression, and usually a honeymoon phase. But immune checkpoint inhibitor-induced type 1 diabetes? It is shockingly rapid. There's no prodrome, it presents immediately with diabetic ketoacidosis, and the beta cell destruction is permanent. They'll need lifelong insulin.
Let's look at another regulatory failure. Section 4, IPEX and thymic tumors.
Imagine what happens when you completely lose your T regulatory cells. Without the FOXP3 gene on the X chromosome, infants lose absolutely all peripheral immune tolerance. The result is the devastating IPEX syndrome. This leads to the most severe neonatal diabetes imaginable, often presenting right at birth in around 80% of patients, along with severe enteropathy and skin disease. And because this is a profound structural deficiency of Treg cells, standard immunosuppressants are just a temporary band-aid. The only definitive curative treatment is a full hematopoietic stem cell transplant to entirely replace that flawed immune system.
Now let's look at the thymus gland from a totally different angle. If you see a full-grown adult suddenly develop mucocutaneous, candidiasis, and anti-cytokine antibodies, your first thought should absolutely not be a spontaneous APS1 mutation. Remember, that's a childhood disease. Your first thought needs to be a malignant thymoma. You see, thymomas lack the AIR gene in their tissue, which triggers this wild autoimmunity. The most common association is actually myasthenia gravis at 44%, followed by pure red cell aplasia. Interestingly, surgically resecting the tumor can actually offer a temporary remission of these autoimmune symptoms.
All right, prepare for a rapid-fire showcase. Section 5, Rare Endocrine Syndromes.
First up is Cros-Fakasi syndrome, which is brilliantly remembered by the POEMS mnemonic. These patients usually first present with progressive demyelinating peripheral sensory motor neuropathy, that's the P. Then comes O for organomegaly, E for endocrinopathies like diabetes and primary hypogonadism, M for an M protein spike with these really unique sclerotic bone lesions, and finally S for extensive skin changes.
But here's the really interesting part. The actual biological culprit driving all this chaos in POEMS syndrome is vascular endothelial growth factor, or VEG, not just the M protein alone. This massive excess of VEG causes widespread vascular permeability, which leads to that severe nerve damage. And that's exactly why treatments that lower VEG levels, like lenalidomide paired with dexamethasone, or even stem cell transplants, can effectively drive this complex disease into complete remission. Another incredible mnemonic we've got to cover is DIDMOAD, which tracks the inevitable, steady march of Wolfram syndrome. Driven by the recessive WFS1 gene, these patients suffer from diabetes insipidus, childhood-onset diabetes mellitus, optic atrophy, and sensory neural deafness. As the disease progresses, the diabetes and optic atrophy are literally always present. But here is the massive clinical twist. Despite looking exactly like autoimmune type 1 diabetes, the diabetes in Wolfram syndrome is uniquely driven by non-autoimmune cellular stress. Specifically, it's endoplasmic reticulum stress that leads to the beta cell destruction. If you run a panel on these patients, you will find absolutely zero islet autoantibodies. It's a completely different mechanism of endocrine failure masquerading as an autoimmune disease.
Let's bring all these complex threads together. Section 6, Master Comparison, APS1 versus APS2.
This nicely synthesizes our journey today. On one side, we have the inevitable childhood genetic breakdown of APS1, defined by that AIRE gene mutation. It brings the classic triad of candidiasis, hypoparathyroidism, and Addison's early in life, and it's flagged perfectly by a 100% sensitive marker, anti-interferon autoantibodies. On the other side, you've got APS2. It's polygenic, it's driven by HLA-DR3 and DR4, and it hits adults with a combination of Addison's, autoimmune thyroid disease, and type 1 diabetes. Understanding this contrast is absolutely crucial. It's the bedrock of diagnosing and safely treating these incredibly complex patients. As we push the boundaries of modern medicine, from selectively manipulating T cells to delay diabetes, all the way to entirely unleashing checkpoints to cure cancer, we are constantly walking a biological tightrope. And so, this is the ultimate puzzle of immune tolerance we are left to solve. How do we harness the incredible, destructive power of our own immunity without becoming the casualties of our own internal defenses? Keep that question in the back of your mind as you process everything we've unpacked today. Thank you so much for joining me on this explainer, and I'll catch you next time.